Newton-Wellesley Medical Group Lunch and Learn. Today we are excited to have Dr. Ellie Tomczyk here, one of our new plastic surgeons on staff here at Newton-Wellesley Hospital. And she's going to be talking to us about breast implants, buzzwords, and hot topics. If you can move to the next slide for me, Elle. As usual, you can apply for CME credit by using the code CUZWEW. I'll put that in the chat box towards the end. CUZWEW. Next slide. Just wanted to tease the upcoming Lunch and Learns. Next week, we have a great talk by Andy Freiberg, joint replacement surgeon, and he'll be talking about hip and knee replacements. And then the following week, we will have a great talk by Gigi Sheftel, one of our staff cardiologists, Echo Lab update, clinical pearls, and takeaways. So we're excited about those two talks in December. And just so you know, we are booked basically all the way through January with talks as well. So we're excited to keep this series going. If you want to look up these videos, they're on YouTube. You can search Newton-Wellesley Medical Group Lunch and Learn. Before I let Dr. Tomczyk take over, I just wanted to tease two things real quick. Next slide. We've been out wide with we have our third year of wellness grants for our physicians. I wanted to focus on the two grants. The three grants are up there right now. These are the three new ones this year. The Physician Concierge is on the bottom, and the top one is the Virtual Fitness Program. We're getting a lot of questions about the Virtual Fitness Program, the Peloton app. So I just want to make sure folks are aware of that. If there's any questions, you can email myself or Leland Bixby, B-I-X-B-Y. He works with the PHO and Jeff Murphy's team. Next slide. Just so people know, we are reimbursing good for 1 year membership. It's a monthly charge. So 11 months of bills can be submitted. There is a survey that needs to be done, a pre-survey and a 3-month survey. If you ride on Peloton, we have created a hashtag, hashtag NWH Strong. Go ahead and add that to one of the 7 tags you're allowed, and go ahead and ride on that so we can ride as a crew whenever we're together. And next slide, now I'll stop talking and I'll turn it up. Last one is the Physician Care Concierge. This is a great service. You kind of log on and email and you can ask them any questions. I needed a contractor for my house, and we just kind of emailed them the problem, and I got 4 names that have been vetted, so pretty good. All sorts of services available, all free to you if you sign up with the welcome code NWH. And if you don't have any more information about that, you can email myself or Audrey Bossi on this. Next slide. Okay, Ellie, take it away.
Awesome. Can you hear me okay?
Yes, we can.
Great. Like Dr. Snyder said, I'm Ellie Tomczyk. I'm a new plastic surgeon here. I did my residency at UMass and a fellowship at Mass General last year, and then was hired to be part of the Mass General group, but mostly be at Newton-Wellesley. This is really my home base. This is where my office is. This is where I see patients. I had the opportunity to speak to the family medicine group, give grand rounds on breast reconstruction, which is something I'm really passionate about. I am a true bread and butter plastic surgeon. I do everything from lumps, bumps, skin cancers to major reconstruction with our other surgical services. So when asked to give this talk, since it's a shorter amount of time, I thought it would be kind of fun to pick something that's hot topics in the media right now, which are breast implants and things that I think many people, no matter what your discipline is in medicine, you might have patients with implants who have questions or have read something. So I thought that this would be a fun way to get started. So a lot of people these days are getting information from social media and the media in general, and this is the prominent source of their information, for better or for worse. And that's why this comes up a lot, like I said. So these 3 things, ALCL, BII, and the new black box warning on breast implants, I thought were 3 of the hottest topics right now. And I'm going to go into each of those quickly. These are just a few headlines that have been released over just the last year or so on very mainstream media venues. U.S. News and World Report, the Today Show, the New York Times, it's all over the place. These very scary, horrible sounding trade lines, and this is what patients are reading, and this is what they're saying. Oh my gosh, my implants give me cancer and no one told me about it. And that brings us to BIA-ALCL, which is breast implant associated anaplastic large cell lymphoma. This is a very uncommon and overall very treatable type of T-cell lymphoma that can develop around breast implants. It's not a cancer of the breast parenchyma itself. We're still learning about it. We don't fully understand the true pathogenesis of it. And that's why things like the profile registry were developed to try to really get a better sense of the numbers. If you look at that first bullet point, the range in what we think the occurrence rate is huge because we just don't understand it well enough. So on average, this develops 8 to 10 years after implants were placed. That means down the line, something changes. The most common presentation is a delayed seroma. So you would see this very obvious change in the size of the breast, and you would probably be able to see that there's fluid in that breast just on clinical exam. That's a big concerning symptom to see down the road. You can get seromas for lots of reasons, but it's not super common to get them that late. And that means you need to start a workup for it. At this point in time, there are no cases that were confirmed in smooth implants alone. There are patients who've had smooth implants, but they've also had a textured device at some point in their history of breast implants. So right now it's only linked to textured implants. Because of that, the textured implants, as many of you might know, were taken off the market by the FDA last summer, specifically the Allergan implants. I actually have never used a textured implant. They have benefits to them, certainly, especially with reconstruction, but because when I started training, ALCL was starting to become a buzzword, we were learning more about it, we just never thought it was pertinent to use them, given the potential risk. The majority of patients who do get diagnosed with ALCL are absolutely cured by taking out the implant and the capsule, which is the scar tissue around it. And we recommend going ahead and doing both sides. There are rare patients that go on to need chemotherapy, radiotherapy, and more intense treatments, and there are reported deaths from this. Again, that is rare, and the patients who have that typical clinical course presented differently, typically with lymphadenopathy or a large palpable mass. That must mean there's something, a stronger form of this going on in their body. So how do we make the diagnosis? This is part of the NCCN guidelines that were developed by some of the key hot people in plastics who've done a ton of research on this, mostly out of MD Anderson. Just like with most forms of cancer, there's a process that you go through. Like I mentioned, most patients present with a seroma, which is the fluid collection around the breast. So what do we do about that? Well, you need to sample that fluid and send it for a CD30. The key is that you actually need more than 50 mLs of that fluid. That's a lot. That means that this pretty much is a huge seroma. That way, clinically, you're really not going to miss it. That's a lot of fluid in that small cavity. So if they come with some odd symptom, we start with some imaging. We try to sample the fluid if there is fluid. If there is a mass, we biopsy the mass. And then based on the results of that, we go down the pathway of how do we treat them. So again, if it is diagnosed based on the biopsy of a mass, or most commonly based on the fluid from the seroma cavity, then you take the patient to the operating room. In general, the treatment for this is surgical. You take out the implant and you take out the capsule that surrounds it, and that is curative. Depending on the extent of the disease and other things, then you would potentially need to go on to have other forms of therapy, such as chemotherapy. And we do follow these patients with PET scans as well to make sure that we're not missing any metastatic disease. Again, this is treated just like any other form of cancer, despite its very specific nature of it, and it has its own TNM staging classification, which would look pretty familiar to any other TNM staging of all other cancers. I think these pictures are great. This was a published case report from MD Anderson of a 32-year-old female who had a rapid onset of right effusion. So she developed all of a sudden tons of fluid on one side. This was about 6 years after a cosmetic augmentation with a textured device. They sampled the fluid, which you can see in the center picture. They sent it for a CD30. You can see in the pathology in the slide the abnormal cells, and she was taken to the operating room, given that diagnosis, and underwent a capsulectomy and all the things I just said. So you can see it, even in that top left picture, if you look closely, it's not subtle, the difference in size of those two breasts. That right breast is significantly larger. In the bottom right picture of that little foursome cluster, you can see that's the implant sitting within the capsule, which is the scar tissue that forms around it. In the far right picture, you can see they're taking the capsule off of that textured implant. So we're going to change kind of topics a little bit because I want to hit on all three of these key things. So this is BII, breast implant illness. I personally think this is one of the most controversial topics in plastic surgery right now because of its very broad range of symptoms, the lack of clear diagnostic criteria, and absence of long-term safety and efficacy data. We just need to better understand the interaction that certain patients have with their implants. We think that some patients develop a form of an autoimmune disease or something in a similar pathogenesis as an autoimmune disease when they have a foreign body, such as an implant. Patients present with this vague constellation of symptoms and asked to have their implants removed. We don't really know what patients we can help and what patients we can't, and that's what a lot of the research is going into to better understand this. There are many plastic surgeons out there that actually advertise themselves as explanters, meaning come to us, you have BII, I'm going to fix you by taking out your implants. But that's not always true. You can have a patient who has these vague symptoms, whether it's a psychological thing or they have something else going on, and you take out their implants and they're no better, and now they're just unhappy. This is one of the published reports of what these symptoms can look like. Again, very vague, very non-specific, and that's what makes this so difficult. And they're very similar to many other autoimmune disorders. And that's one of the ways that we start working them up is we send off the similar panels to see if they're elevated. This is clearly some kind of inflammatory driven exaggeration of the immune response, but we just don't fully understand it. This is how we're trying to classify it right now. So type A, B, and C, whether we think they're going to improve with explant. So if we know they have an autoimmune disease, we have labs, we can prove it, they're probably, that's probably something else that's going on, and they're not necessarily going to improve. However, if they don't necessarily have some other cause for all these symptoms and everything else is ruled out, then it's certainly possible that by taking out the implant, they're going to get better. Bottom line is, from my perspective, it's my job as a clinician to listen to the patient and do what I can to help. I'm not 100% sure this is a real entity. I'm not 100% sure we can make patients better. But I know for a fact that there are patients who get their implants out who feel better. So if a patient comes to me and they have symptoms that they kind of correlate with the timing of their implant, I'm up to discuss it with them. I'm happy to remove the implant, but I would always counsel them that I might not be able to help them and it might not fix the problem because there could be something else going on. I put this in here from this really great article about the proposed pathogenetic pathways. And if you look at the bottom, it's leading to ALCL and BII. So both of these entities seem to come from this similar overdrive of the immune response to this foreign body. We, again, don't fully understand it, but there seems to be some common pathway. And hopefully that means we can target this and figure out how to eliminate this from happening or identify patients ahead of time who might have a tendency to go into overdrive and not do this to them. Again, stay tuned. We'll find out more. Moving on to the new black box warning for implants. This is the exact label that they're putting on the implant box. This is what the FDA released. This really came out in the wake of all these investigations related to ALCL and BII. Breast implants are actually the most studied device on the market in medicine. So more so than pacemakers, more so than the knee replacements, it is the most studied device. This came out in 2019 after an expert advisory panel heard from patients, medical experts, cancer experts, and they decided that this was what needed to be done. It talks a lot about, it goes on and on about what needs to be done. It talks about how emphasis that breast implants are not lifetime devices, that they might not last forever, requiring more surgery, the screening recommendations for rupture and for ALCL and what needs to be done. They have changed their typical screening recommendations for how to monitor implants long term. They want all these check marks done when you're consenting a patient to use an implant. You have to disclose the risk of ALCL, even in a smooth implant, because we don't know for sure. You have to discuss BII with patients. So the bottom line is, this is really scary if you just saw this. And, I'm a surgeon. It's my job to disclose as much as possible to my patients. And so when I'm consenting any patient mostly I do breast reconstruction and I do it with implants. I go through all of these things with them. I explain what ALCL is. I explain that we don't really understand it well, but it is possible that I use smooth implants. So we're hopeful that that will not lead to it. I talk to them about BII. I use the car analogy when explaining implants to patients. I say, listen, it's like buying a car. You go to the store, you buy a car, you expect it to last, around 10 to 15 years. Some cars will last 2 years and some cars will last 30. Obviously, 2 and 30 are the extremes. And on average, they last about 10 to 15. A lot of women that get breast cancer are only in their 40s or younger. So they're absolutely going to need another surgery in their lifetime to replace that implant because of things like capsular contracture and other issues that they have with it. It takes a lot to rupture an implant, but a 30-year-old implant will rupture much more easily than a 2-year-old implant because things just kind of deteriorate some with time. So I just try to be really honest with them and lay the groundwork from the get-go so that when 15 years rolls around, they're having a problem, they say, oh yeah, I knew I was going to need this. I don't automatically exchange implants at 10 years or 15 years. If they're having no problems and there's no sign of rupture, live your life. There's no point in messing things up if you're happy with things. I'm seeing a patient later today who has an incidental finding of a rupture. And that's the thing with silicone implants. We often don't even realize they're ruptured. She had a mammogram. This imaging revealed this. But knowing it's ruptured, I would recommend removing it. We can exchange it. We can do a mastopexy instead. There's lots of things we can do, but I don't like to leave a known ruptured implant in somebody, even though we don't have great evidence it's going to cause any problems. So that's all the scary, hot stuff when it comes to breast implants. At least it's out there now. This is my 2-year-old son, who I'm very proud of can rock his mask. And it makes me say anybody should be able to do this if a 2-year-old can wear a mask. And I'm very proud of him for doing so. But I'm happy to take any questions or anything like that.
Thanks, Ellie. It's John Snyder again. It looks like Lucy Panesian wants to know, does saline versus silicone make any difference? Excuse me. Does saline versus silicone make any difference in the frequency of BIA, ALCL, or BII issues? And can textured implants be either saline or silicone?
So that's actually, those questions kind of go hand in hand. So actually there are not, I guess there technically are saline textured implants. We really don't use them in the States. We actually don't even use a lot of textured implants in the States. So a smooth saline implant does not have an increased risk or a lower risk. It would be the same as a smooth silicone implant in terms of ALCL. But any textured device has a risk. And then even within the textured devices, not all textured implants are created equal. So they have different techniques for how the shell is textured. The reason texturing came about was because we wanted to create implants that were in that teardrop shape that look like a more natural breast, which is very helpful in reconstruction because you have to reconstruct the entire breast footprint after a mastectomy, and a round implant doesn't do that. That's why we really started using them in the United States. But they make textured round implants, and they're used especially in South America, Brazil. Brazil is a huge place, a lot in Europe as well. They're using them for more cosmetic reasons. And while that is used some in the United States, it's not as frequent.
So I had a question about screening for breast cancer with these patients who have these implants. Is there any data that MRIs are superior than mammograms? And this is not for reconstruction, but just routine screening on patients?
Not to my knowledge. In general, what the data has shown is that having a breast implant does not inhibit your ability to have normal routine breast screening. So mammography works just as well. And I think part of that is that our radiologists are so attuned to reading this, and it doesn't hide the breast. So they're so used to seeing this that they don't really have an issue. So there is not an increased risk of delayed diagnosis because you have an implant, and we don't automatically go to an MRI because you have an implant. You go through the standard same route. And again, I think that really is because our radiologists are so good and they have learned to accommodate all the things we do.
And then a couple other questions. Does a saline implant ever cause BII?
I actually don't know the answer. I mean, there are textured saline implants. So I would have to go back and look. I haven't seen a list of every single case that has been diagnosed, but I would presume at least some of those are saline because they're textured, but not a saline smooth. That has
so the filling, you're saying the filling is not as important as the texture?
It has nothing to do with it. Yeah. The saline implants, the big thing with them is when the silicone implants were brought back on the market after they were taken off in the 90s, there were limitations, and you have to be a certain age actually to get a silicone implant. So young women, especially young women who have something like Poland syndrome, right? So it's a congenital absence or not full development of the breast, among other things. Oftentimes those women want to be reconstructed and have surgery sooner and have an implant young, like at 18 or 16, because they want to look normal. So those ages, you have to be 22 to get a silicone. So young women get saline implants. They don't feel as natural. You certainly know when they rupture because the saline just dissipates everywhere and it gets reabsorbed in the body. So you'll go from a breast to flat instantly. And they're cheaper. So those are the main reasons why you get them, but they're not linked to ALCL.
Aside from political issues, why would silicone have an H and saline not? Okay.
No, I don't really. I think it was just what they agreed when they brought it. I mean, this was in the early 2000s. They brought them back on the market. And I kind of think in the future that's going to go away. But there's still, I think, this fear that when silicone escapes after a rupture, it can travel, it could cause problems, but it's just so rare because now we use this high medical grade silicone that's highly regulated, and so we just don't see those problems. So,
right. A couple other questions. Let's see. What is the risk of implant rupture from a mammogram itself?
Low, really low. I've seen it. Or I've seen it that they think that's what caused it, and it certainly can. I would say it's like those 30-year-old implants that are on their last leg, or might have had a partial injury to the shell, and then the mammogram kind of sets it over the edge. But if you've ever held a breast implant, or if you're curious, come up to my office. I have lots of examples of them. It takes a lot of force to break them. Like I always tell my patients, like, you almost have to be in a car accident and have your chest hit against the steering wheel. It's that kind of force to rupture them. You can really squeeze them. So it's pretty rare, but it certainly is possible.
And two other questions about saline implants. Is there a risk of the autoimmune disease that you described with saline implants there too? I think you answered that. It's more about the texture in the shell versus the.
Autoimmune illness, we don't really know. That is, any implant can theoretically cause that, and it's just having a foreign body. I actually don't know if I would have to look it up and see. I've never seen it separated out between silicone and saline, but they think it's just this having a foreign body, period. It sets off this inflammatory reaction.
Okay. And then last one, are saline implants more likely to rupture versus silicone?
The shells are slightly different. They are, I think, a little weaker than the silicone, but now they're supposed to be similar. They're supposed to not have the same rupture rate. On paper, they have the same rupture rate. It's just that you would notice it.
Okay.
If they had a worse rupture rate, I don't think you can get away with using them.
Great. And so I don't know if you want to talk about your practice a little bit. So you do a lot of breast reconstruction around cancer surgeries, et cetera, but also routine plastic surgery, right?
Yeah. I would say I'm that general plastic surgeon. I dabble in everything. I love being a bread and butter plastic surgeon. I think I mentioned quickly at the beginning, I do anything from like lumps, bumps, lipomas, little cysts all over the body. I do skin cancers or skin cancer closures. And then I do some cosmetic. I really like the post-bariatric body contouring. You lose 150 pounds. Obviously, you have a lot of redundancy of skin, so taking care of that. I'll do tummy tucks, breast dogs. I try to stay away from the facial aesthetics. It's just not my passion, and people that do it all the time should do it, and that's not me. But I'm also really involved in the wound center here that we're really revamping, and it's been amazing. There's such a great team already here, and I think we just have room to grow and improve. So I personally love wound care. It's overlooked a lot of times, but it's a huge need. So I really enjoy doing that. And my favorite part is I get to work with all the other surgeons. Like spine has a problem or a difficult case, I can come in and help close. I'm doing cases with colorectal, vascular surgery, because I can bring in healthy tissue and fill holes in random places. And that's the beauty of being a plastic surgeon, is I'm like this go-to person, which I really love.
Filling holes in random places. Well, thanks, thanks so much.
That's what I do.
I know that you're seeing patients up in our green suite, our surgical suite 563, and she can be reached obviously any way you can refer surgeries, either Epic or phone or whatever. Thanks so much for doing this. We'll see everyone next Thursday. Hope everyone has a nice, enjoying weekend. See you all later. Bye.